Well, good afternoon and welcome to this second of a series of 6 creative exchanges that will lead to a fantastic conference in September where we really grapple with some of the design solutions that are available to some of the social ills that we have to overcome in Cape Town, in the Western Cape in South Africa, and indeed the African continent. My name is Melane. It's a joy to be back here again. We'll be in your company for the next hour and a half, where we bring you 5 speakers in total this time around. The first 2, focusing obviously on healthcare in this country, are going to be setting the picture, if you like. What is the current situation in South Africa and how we can perhaps posing some of the important questions that some of our creatives will need to respond to. The 3 speakers then after that will talk about the work that they're currently doing and how that could possibly be applied to a South African context in realizing some of the solutions that we are looking for. In the hour and a half, we're going to ask you to be part of the conversation, please. You can use the chat function on this platform to pose any of the questions. And do not wait until I ask you for questions. Keep them coming, because as soon as I have them, I'll be asking the panelists on your behalf of that question. In a moment, I'll be introducing you to the various speakers today, but let's pause for a moment and reflect the significance of today. It's day 2 of the sitting president of the Republic of South Africa, sitting at a commission that is inquiring as to state capture, being posed questions by senior advocates to the full view of the public glare. When has that ever happened in a South African context? Sadly, we have a former president who's denying South Africans the pleasure of him answering some pertinent questions, and that's something really to note, I think. It's also important to note that as of yesterday, the Sisonke trial resumed, where the healthcare workers continue to receive the Johnson & Johnson vaccines. 17th of May is a big day for the rest of South Africans. If you're over 65, I cannot stress enough the importance of you going to the Department of Health's portal and register for the vaccine. The Western Cape government promising that all of the over 60-year-olds will be vaccinated by the end of June. That's a bold goal, and I'm sure they will achieve it. We cannot stress enough the importance of getting that vaccine into your body as soon as possible so that we can go to full return of the economy and economic activity that will obviously ensure that many of the social ills we'll be discussing in these creative exchanges are addressed in some way. With all of that out of the way, let's say hello to the man who will be hosting us every time for the next 6 conversations. Well, we have 5 left, including this one. He is, of course, the Consul General for Cape Town for the Netherlands Embassy. A very good afternoon, Sebastiaan. Lovely to have you here again.
Thank you so much. Can you hear me?
Yes, we can. Yes. This is the second of what is a series of 6 conversations. Yes. In the first conversation, we really, I suppose, painted the lay of the land. And because we're in the middle of a COVID-19 pandemic, realized that healthcare is going to be one of the most important conversations we need to cover.
Definitely. Before I want to go into that, of course, we're sitting in the old granary here in Cape Town of the Desmond and Tutu Alea Foundation, Desmond and the Tutu Foundation, which is quite a beautiful setting to be in. Because, of course, we know that the Archbishop is very much connected and is very much connected with everything that's going on, not only in South Africa, but in the world. So I feel very honored and humbled to be sitting here right now. Yes, it's quite obvious that healthcare has risen in the priority of everybody because we have the pandemic. And it's creating incredible big challenges for livelihoods for everybody. People are losing their jobs over lockdown measures. People are sick and ill, and some people are dying because of this. And these are challenges that are so huge that we cannot avoid having to look into this, and we will with great enthusiasm. And one thing I also have to compliment you on and also what happened last time. What I find striking in South Africa is people are not afraid to also debate taboos and also debate the hard facts. And I'm really looking forward to today to hear the exchange between the real specialists, the people that know, on what we're facing and what we should be talking about really, and maybe what people are forgetting to talk about.
Indeed, and what's key to this series of exchanges is that we need to have takeaways, right? Action points that are going to be measurable so that in 6 months' time, in a year's time, in 20 years' time, we can say this is how we've shifted the needle, in this case, the space of healthcare.
Definitely, and it's going to feed into Co-Create Design Festival later. So I hope that will be this will be like a springboard into that, where we can take things further.
Lovely to have you here. And by the way, happy King's Day to you and the people of the Netherlands for yesterday. Thank you. Thank you very much. Well, Erik has been heading up the CDI, the Craft Design Institute. You conceived this nearly 2 decades ago because sadly, social concerns have been around for that long in the South African context. And design, you believe, truly has a solution to some of these concerns.
Yes, Africa. So I think I'm really looking forward to today's session because I know very little about healthcare in South Africa, to be honest, apart from my experience of it as a, I want to say consumer, but as a user, as a patient. And I think that we've got sort of fantastic speakers lined up so I'm hoping that we'll really learn about what the state of healthcare is in South Africa, apart from what we just read in the press. And just reflecting on it, it seems to me that there are so many opportunities for creative solutions and for innovation. So I'm really hoping that that is also what comes out of the conversation, a sense of the reality of the challenges that aren't just COVID challenges, they are also pre-COVID challenges. And how do we apply ourselves as the amazingly creative nation that we are to come up with solutions to some of those really challenging problems?
Indeed. Both Sebastiaan and Erik are going to be staying with me, or with us rather, and of course we'll bring them in towards the end of the session. A reminder, if you have any questions for any of the speakers, you're most welcome to use the chat function throughout, and we'll make sure that your questions are posed. Dr. William Mapham is sitting next to me. He's only speaker number 3, so I'll introduce him then. William, it's lovely to have you here. But let's go to Johannesburg first and speak to Russell Rensburg. Russell is the director of the Rural Health Advocacy Project, and he's an expert in health systems and policy and was a commissioner of the Lancet High-Level Commission on Quality Healthcare. And he's going to be talking to us about, I suppose, what the situation really is in South Africa right now. What is the state of affairs? What are the challenges? And more importantly, where are we headed? Russell, lovely to have you here. Good afternoon. What is the state of affairs in South Africa right now? What are some of those challenges we need to overcome? And most importantly, where are we headed?
I think that with most design questions, we have to start with the problem that we're trying to solve, right? And I think in South Africa, we can't do anything without really considering our principal problem. And then for me, that problem is the poverty, inequality, and unemployment. We live in a country where 60% of the population essentially are living below the breadline, part of the working poor. They are structurally unemployed, particularly in the rural communities where unemployment is up to 90%. So often you have people that either never had a job, never likely to have a job, and are also completely reliant on state transport. Right, and I think in our 25-year history, or 27-year history, now on the 27th of April, as we reflect back on that, we have to start asking the question, do we understand the problem that we face as South Africa? Are we invested in the right kind of things to enable us to address that problem? And what are the steps that we need to take in order to get there? And I think the onset of COVID in March 2020 really just amplified some of those challenges that we face in the country. Least of all which in our healthcare system. Now, one of the things that I often reflect back on as I think about this journey, I look at on that whole constitutional process. And there are many people currently who feel that we got a raw deal when we negotiated the settlement in the 90s, and that while the Constitution promises a lot, ultimately it doesn't deal with equality in a manner that is progressive and looks at investing in people out of the poverty trap. But the thing that I like to focus on when I look at the Constitution is the preamble, and a particular clause in the preamble, which for me is like a call to action. And I think besides just addressing the injustices of the past, I think we the people also commit ourselves to a process where we want to improve the quality of life of all citizens and free the potential of each person, right? Following on from that, we look at Section 27 of the Bill of Rights, or the Constitution. And this deals essentially with the broader determinants of development and allowing us all to equally participate in the joys of this country. You know, the first, in those rights, we talk about everyone has the right to have access to healthcare services, including reproductive healthcare. B, sufficient food and water, and social security, including, if they are unable to support themselves and their dependents, appropriate social assistance. These are constitutional rights. Often we know a lot about access to healthcare or rights to healthcare because of the work done by colleagues at the Treatment Action Campaign and elsewhere in the fight to opening access to ARVs to people living with HIV. But when you think about the right to food and the right to water, many of those rights were, or the deficit in those rights were amplified during the initial lockdown and really just extended during the second one, where sometimes the greatest risks to rural communities was the lack or the cut in social transfers, not being able to access food, the slow timing of the government's social security or social assistance programs, and in many ways amplifying other health risks as we move forward. Right, and the caveats within this Section 27 rights that are guaranteed to all South Africans, or all who live here, because we have a very broad definition of citizenship, is that the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of this right. No one may refuse emergency medical care. And I think the reason why I tried to focus on the slide was really, when I later on get to the experience of accessing care in COVID, we can see in many ways that a lot of these rights, particularly the health rights and access to emergency medical treatment, was largely ignored. So when we think about realizing in the progressive measures that we've taken as a country over the last 27 years, you know, they've been significant. You know, I think often a lot of healthcare advocacy and legislation is very like supply side orientated, where we focus on the infrastructure, we focus on the staff, we focus on so many different things that often the people are left behind. You know, and I think that's one of the areas where I think designers can really make a big contribution, is understanding how can we sort of de-science healthcare delivery and really just think about how do we have healthcare that's responsive to the needs of the people that it's trying to serve. But I think the state of our current healthcare system is one that has been in the media for some time, even before the pandemic, when we started talking about the national health insurance. Some of the things that were put into focus was the two-tiered nature of our system, where the 20% or the elites have access to a world-class private sector, right, through medical schemes and sometimes also out-of-pocket expenses. And then a large investment from the state, which is around 220 billion rand per year, that is spent on delivering healthcare through over 4,000 health facilities, which includes 600 hospitals. Over 180,000 healthcare workers are employed by the state in various capacities. But sadly, a lot of those capacities are also just concentrated in the large metros rather than across the 52 districts of our country. The next aspect we want to look at is obviously what is the problem that health tries to address. And unfortunately, health is one of those issues that has essentially stayed the same for the last 100 years. Right? As much as we go out and we talk about health, or health not necessarily being the absence of disease, but rather something that over the extent of our lifetime, we are able to access those aspects of healthcare that both amplify our potential and give us the care that we need when we need it, where we need it. So when we look at South Africa's burden of disease, you know, I think it's difficult to decouple our story from the massive challenges we had in the early 2000s around the access to treatment for HIV. We have massive increases in mortality over that time. And to a large extent, we've partially addressed that, where life expectancy for both males and females have started creeping up as more and more people have access to life-saving ARVs and the like. But the battle's not done. You know, we still have, when we start disaggregating these things on a racial level, because inequality in South Africa is unfortunately also racialized, and it plays out in the way that people access healthcare services. You'll find that life expectancy amongst the more or let's rather say the previously advantaged group, is higher than life expectancy amongst the black majority. And I think if we think about progressively realizing the right to health or to a better life, I think that's one of the areas as designers and advocates and administrators we need to start looking at. How do we narrow that gap? But currently, you know, the disease burden in South Africa is like, we're sort of in that perfect storm. Everything that's a challenge is a challenge for us. We have a rise in non-communicable diseases, you know, particularly diabetes, which is often diet related. And a lot of that diet related is often also linked to the consumption of ultra processed foods. Not so long ago, we had the listeriosis crisis, you know, where something as innocuous as polony, right, and poor production processes around polony led to over 100,000 deaths. I think it's underappreciated just how many people got affected by that, and it gave us an indication that often the poor's only source of protein are these ultra-processed foods, which are high in salt and can often also have a negative health impact with a greater increase in hypertension, and it disproportionately affects the poor. So I think part of our future in looking at health is also looking at the broader determinants of health and the relationship between food and health. We also have a situation in our country where diet also has an impact on development. You know, so if you don't receive appropriate nutrients in the first 1,000 days of life, you know, it can have a lifetime impact on your broader development and can lead to underachievement in school and getting caught in a poverty trap. And that's often the case for a lot of rural communities who are almost solely reliant on the state pension and some child support grants in order to sustain that. And even when we combine that, the average income, maybe for a rural household of around 7 could be around 4,000 Rand. There's a project in the Pietermaritzburg Economic Justice Project for recent publishes monthly barometer that sort of evaluates the cost of a food basket for poorer communities. And this is the moment standing at 4,100 Rand. So if we just consider the income and the expense, and we don't even think about things like airtime and electricity and other things like that that the poor pay for, you know, the investments that suffer are the investments in nutrition and health and good food for that community. And we look for rather big volumes of food rather than food that sustain and help us. And in addition to obviously non-communicable diseases, we continue to suffer with things like diseases related to pregnancy. You know, our maternal mortality rate is amongst the highest in the world. It continues to trend down, but it's still double what even the Millennium Development Goals were, let alone the SDGs, which are a little bit less focused. But it continues to show us that the health system that we have, particularly in the public sector, is not responding to the healthcare needs of the community that it serves. Immunization coverage. You know, we also look at the distribution of these diseases. You know, the poor suffer greatly. I think maybe we just want to refer back before we go to the COVID impact on the healthcare system. You know, one of the challenges that we face is sort of the youth. I'm sorry, I'm looking at the questions as they're coming up. But, you know, one of the challenges that we face going into COVID, and why a lot of us felt that an initial decision to go into a hard lockdown was the correct one, was that when we went into it, we didn't know that much. But what we did know was that people that were older than 50 or people that lived with uncontrolled diabetes were at greater risk. And when we looked at the South African numbers, in South Africa, for instance, there are 4.5 million people living with diabetes. Of that 4.5 million people living with diabetes, less than a third are on treatment, right? That's around 1.2 million people. So from a risk assessment point of view at that time, you know, there were potentially 3 million people that were at risk of severe complications related to COVID. And most of them are poor because they aren't able to access the care that they need, or the care isn't available where they are. Diabetes, a lot of the conversation at the moment around fixing the patents or opening up COVID technologies, you know, ignore some things like insulin, which is probably one of the more expensive drugs, despite it being out of patent for a number of years. And there's a lot of profiteering, but often with COVID and with other things related to COVID, some of these long-standing health system issues are underappreciated or under-advocated. So in addition to that, since 2006, we've invested heavily in HIV care, often from own resources as well as the generosity of our friends in the global community. I think we can count the Dutch as part of that, as big supporters to the Global Fund and the like, which makes significant investments in South Africa. Like I say, I think we have around 7 million people living with HIV in South Africa at the moment. Of that, about 4.5 million people are on treatment. We don't have a clear idea exactly how many people we have in treatment, because the measures in where we count them are people ever enrolled rather than people currently on treatment. So we could have a little bit of double counting. But HIV is one of those things that we can solve in our lifetime. And a lot of that is based on this idea of 90-90-90. I'm not going to try and over-explain it, because I know you guys are not normally working in the healthcare sector, but what it essentially translates as is that 90% of people who are living with HIV need to know their status. Of that 90% who know their status, 90% needs to be on treatment. And of those 90% that is on treatment must become virally suppressed. And when they say virally suppressed, it means that when they do a viral load testing, the disease is almost undetectable. Right? But in order to achieve that at a population level, we need to move from the current level of 60 to 70% of people living with HIV on treatment up to 90%. And that's been a very, very sticky thing to do. And I think part of the problem there is really just understanding the pathways to care and keeping people on care. And sometimes those processes are over-medicalized, and we need maybe more creative, design-oriented thinkers to focus on that problem more specifically, so that we can come up with the kind of solutions that are contextually relevant and medically efficient. As I said earlier, maternal mortality remains a big issue, particularly in rural areas where there's very poor access to emergency medical services. And again, this is one of the issues where in South Africa that's under-advocated. So when we talk about emergency medical services as health activists and advocates, we almost focus the attention on the state's inability to deliver. But I think what few of us understand are some of the dynamics that underpin a functioning emergency medical system. So how are we using our ambulances? How are we deploying them? How can we deploy them more optimally, more efficiently, more equitably? And I think the design community, has a big contribution to make in trying to solve that problem. Because I think in South Africa, often money is not the problem. I think inefficiency is the problem. And I think we often see inefficiency as the enemy of equity. But with the right access to information and interpretation of information and the telling of the story in a different way, we think we can solve the problem within available resources. We just need to make the circle a little bit bigger, get people that don't traditionally think about these problems to start considering them. And again, maternal mortality, if we can identify those at-risk mothers earlier, make sure that once we get them to the hospital, that we are able to avoid complications related to pregnancy. Many of these deaths are happening on the operating table, where we are doing cesarean sections in district hospitals, where the competence of the staff is not as developed because they don't do that many of them. And I think this is another area where I hope William Mapham can talk to with his Vula app, are starting to look at how we solve that by making higher level expertise available at the local level, and hopefully that can lay the foundation for better access to telemedicine. Because I think one of the challenges that South Africa faces is that we'll never have enough healthcare workers. And I think we need to start rattling the system so that the regulations can keep up with the technology, and we can deploy the kind of solutions that William Mapham and others are developing to make access to medical care much more available than what it currently is. Because I think often our limitation in expanding care, particularly in rural areas, is bringing in the capacity we need when we need it, and to use it effectively and efficiently. And then the last aspect, or the last two aspects, are childhood immunization. Vaccination and all of those kind of things are in the spotlight now as we look to access a COVID vaccine. But more traditionally, I think we are struggling to maintain childhood vaccinations. When we look at the national data, they'll tell us that we are probably achieving 90%. But in South Africa, our story is a story of 52 districts. We have some areas that do really well, and then we have other areas that do really poorly, but then the average rises. But when we start drilling down to localize the information, the problem becomes quite intense, particularly in the poorer rural provinces where we see vaccination coverage having reduced to below 70%, as opposed to the global average of 90%. And I think it's an area that maybe talks to another aspect of our healthcare system, is that despite all these challenges, our utilization of the health system by patients is actually declining. Right? So in the early 2000s, we could look on average around 3.5 visits per year per person. But more recently, we started seeing that number come back to around 2. So one, people aren't accessing healthcare services, so they're delaying access, regardless of healthcare being free at the local level. So there may be some challenges in how the health system receives patients or talks to patients. And if you look at things like language, for instance, often in rural areas, we find that people are more likely to access traditional medicine rather than Western medicine, because it's more accommodating, more trusting, more available, and they don't feel foreign in it, right? But at the same time, there's this ongoing battle between traditional or indigenous health practices versus Western medicine. And I think this is another area where technology can make a huge difference. We know that China did this early on with their Barefoot Doctor program, where they took, for instance, traditional practitioners and trained them up in basic Western medicine or diagnosis and treatment. And in that way, we're able to bring treatment closer to the community. With us, we have community health workers who can actually act as service linkages between these various communities. But it's, in my mind, more of a design issue than a capability issue. It's really about setting up the services in such a manner that they are responsive to the people's needs. If you look where you are in the Western Cape, for instance, we have a community living with trauma of poverty, trauma of violence, and all kinds of things, and substance abuse, you name it. But there isn't, probably, if you go to a primary healthcare clinic anywhere in Cape Town, you are likely to be able to access substance abuse services or trauma support or anything like that. And so often the clinic is just this place where you go for mother and child stuff. So we're underutilizing that system asset. And again, like I said, it's really just one of those things. Is the problem we're trying to solve the actual problem? And I think sometimes design thinking integrated into the way that we implement public policy is low-hanging fruit. It's really just about reconceptualizing the problem and how we understand it and the solutions that are available to us.
Russell, let me break your word there, because you've given us what really reads like a bleak picture at sometimes. I do not envy Dr. Zwelin Mkhize, not for a single second. To be a national minister of health, working with the provincial ministers of health, just is not a job that you want to be applying for anytime soon, by the sound of things. 220 billion rand is the amount of money we're spending in healthcare. That's the amount of money we have. The likelihood of us getting any more money than that, certainly in the next year or two, not likely. And I think the point that I want to highlight, certainly with the rest of the speakers, is that we have far too many inefficiencies in the system, as you said. We need to be able to maximize what we can get out of that 220 billion rand. We might not be able to address every single social health concern, but let's try and get as many of those addressed as possible. It is unacceptable that there are South Africans who don't have access to adequate health care, when that is one of the, I suppose, the clauses of the Constitution that is enshrined and promised to them. It doesn't make sense to me that we're still sitting with child vaccination challenges where we're not having access to vaccines for children when we know the kind of difference it is going to make. It doesn't make sense to me that the burden of disease continues to rise in the manner that it is, given the amount of money we are spending. Once again, there are many who would say 220 billion rand is not enough, but it is what we have. So let's work with it a little bit better. So perhaps the challenge then to particularly those who are going to be participating this afternoon in bringing about ideas of creative solutions. How do we bring back efficiencies into a health system that is grossly restricted in terms of resources and make sure that we enjoy maximum benefit. And of course, we already have a number of questions for you, Russell, but we'll come back to you in a moment if that's okay. Let me bring in now Fikile Dikolomela-Lengene. Fikile is a co-founder and the first deputy president of the Young Nurses Indaba Trade Union. She began her nursing career in 2005 at Baragwana Nursing School, and where she obtained, of course, a diploma in general midwifery, community and psychiatric nursing. And she is very much one of those healthcare workers who's on the front line in responding to COVID-19. And she'll be talking to us today about experiences that they, as a health sector, are facing. And in addition to that, suppose what the needs are and what the proposed solutions are going to be. Fikile, lovely to have you online. Thank you very much for taking time out of what no doubt is a day for you to talk to us. What is it like on the front line? Good afternoon.
Thank you very much, and good afternoon to everybody. And I'm well pleased to be part of the show. I think I'll be speaking more or less on the practical side of things from a healthcare worker's view, especially how COVID has actually brought much spotlight into the healthcare center, into the healthcare sector, that I feel that we've actually not been zooming our eyes and actually zooming the efforts that needed to be done in the healthcare sector. And it's at the moment when you're working in a public healthcare sector and COVID, you hear that there is a lockdown, and you know all these anxiety and fears which were normal at that particular time started coming up. The fears were not only coming up from the community side, but remember, this was the first of its kind of its pandemic, and most of us in the system, actually, I think this was the first time we deal with such a pandemic of its era. And it became quite real clear when you are in the public sector that, yeah, we're really in for a high jump. Why are we saying that? Because definitely we know that as healthcare workers, we've been saying we don't have Panado, we don't have these, you know, but this time it actually became clear that the society were going to experience this first time. And believe you me when I say that our government actually did not disappoint, because we found healthcare workers wanting in the form of having the appropriate PPE. We found laws being broken just to accommodate, you know, some of the inequalities that exist even inside the healthcare space. And I think that became a clear indicative of the chronic neglect that has been happening in the public sector. And at this time, we can safely say that our public healthcare sector is in the ICU by the way of design. Be it that is a two-tier system that we find ourselves that 80% of the population are using the public healthcare sector, 16% plus minus 16% are using the private healthcare sector, which has close to about 70% of doctors. That cannot be normal in terms if you want to equalize services. That says something out there to us. And one would have thought by design that the elites during this time of COVID would have gotten the better end of the package. And it became a surprise to us as healthcare workers when we felt that those who are resourced actually became the ones to actually crumble, the first cookie to crumble under this immense pressure. Because if one wants to say, based on the design of the careless workforce model that the private sector actually has, actually it saw frontliners taking actually a knock during this time, because profits, I feel that profits were actually put before lives at that particular stage. And I think that's why there were some of the active campaigns that we went to actually for shareholders to say, can there be no shareholder dividends? Can money be directed directly for service use, you know, for resources, for capacitation of those sectors, because we really needed at that time to address, actually to respond, but not to react. But South Africa, in terms of healthcare and design, it has always become a reactive system. You know, when there is a case, when there is a negligence, when there is an incident, you know, it looks like our monitoring tools that I think some of the designers can assist us in. Do we have sufficient monitoring tools, you know, that are out there that are assisting the healthcare sector in better identifying such and actually responding to some of the health crisis that is out there, instead of us having to react to situations that we found ourselves there. In terms of the inequality, COVID for us, I think as an organization, we saw disregard for human life. We saw disregard for rule of life, and we saw labor laws becoming broken because we wanted to accommodate. And it is at this time that it became really significant during the pandemic to actually understand that even the frontliners at this time, I think there was a time when I believed when it started, if somebody had said, I've got 2,000 robots who are willing to come to, I think healthcare workers would have said, bring them on, because at this particular stage, we know the services we work under and the services we're rendering. And at the end of the day, we knew we had to be the ones that go forward and actually hold the fort as frontline workers. Amidst all that was happening, your corruption, because there was a time when people did not even understand when we were talking PPE, what are we talking about? Your protective clothing, a surgical mask and a plastic apron, frontal plastic apron for a droplet or an airborne infection was just not enough. But because at that particular time, rules and regulations were made to be broken so that it keeps the healthcare workers in the space. Remember, testing also became a problem in the public sector, because even in the private sector, because they did not want to test healthcare workers. And then it really hits you to say that one healthcare worker, let's say in a rural clinic, I myself as a nurse, if I see, let's say 100 children, definitely children come with 100 escorts. Now, if I was made to test and go back to work and not quarantine, during the time when I'm waiting for results, when they come back positive, how many people have I infected? Actually, they actually turn healthcare workers into super spreaders because of these types of regulations, these types of laws that were broken at that particular times. And it came to light that healthcare workers also need to enjoy the Section 27 human rights. When it came to the pandemic, they became human, they are human. And I think that became really clear during the second wave, when the front line started to fall, when the front line started to dwindle, when the frontliners now started to raise their eyes to actually see that at the end of the day, they are human. What needs to happen in this part of the healthcare system that we have? 25 years into democracy, it is still normal in South Africa for a woman not to get a contraception because a tender did not go through, because a policy has been delayed. Those are the issues that we are getting. 25 years into democracy, even in the injection of the ART program, you still get issues of conflict, of dilemma, being actually even kept away from the society. Easy access of information that it talks to that there is no easy access of information of our clients. There's a new ART drug, your dolutegravir, that's in the system that sees our clients actually suppressing quite quickly. But you don't hear anything on the spotlight, and it is a major drug, it is the drug. So what does it say about actually in the communities? What message is actually being, what is this thing? What message is actually being taught out there? One thing that needs to be clear, Melane, and the one thing that we are seeing during this time of COVID, is political will. Currently, there is the political will for systems and things to be there. And I'm seeing programs, how I wish I hear how Randall is talking about your expanded program of immunizations of children. I was shocked to see that during this time of the vaccination of the pandemic, we'll be actually having this pool of system where we will be registering everybody in the system, keeping also the data in the system. To me, as a nurse in a clinic who has been struggling to get children to come for immunization, whether be it in terms of adherence, not missing their appointments, wow, I see this program saying, if the political will that we have currently was there from the beginning, even when we're dealing with some of our issues in terms of our expanded program of immunization, in terms of our TB diagnosis, in terms of our ART, and keeping people in the system, it actually says to me, it is possible. It has been possible, but there hasn't been the political will to fix the system. If you'd want to know the percentage of children that we have versus the whole 56 plus minus 56 million of South Africans that we want to put in a system, but we couldn't do that for plus minus 7.5 of our under fives. That says something about our leaders. And I would like to reiterate that we need to be deliberate and intentional about wanting change in the healthcare system. That one needs to go without clear. The African agenda, the 2063 action campaign, the aspiration number 3 for me when I look at COVID and as a health worker in the ground, it resonated with some of the codes that are there to say an Africa of good governance, democracy, respect for human rights, and rule of law is what we want. We need to deal with corruption and looting. And we need to start now facing the problem where it is, identifying it, and also trying to face it. The amazing thing that happened during this time, and I was like, wow, I want to see how we are moving. We want to transition. We want to design our healthcare system into a universal health coverage. But the pandemic actually gave us a trial, and we failed as a country. We failed under the Solidarity Fund. We failed to secure the funds. And it actually saying to us, moving forward into the universal coverage, if we are going to be moving with this kind of design, we are truly in trouble as a country. High standard, quality, comprehensive, that is inclusive of the community, of the community. But more specifically, we need to look at how we are able to, even digitally, decentralize our human healthcare, human workforce. There is a problem in how there is distribution of specialists and specialists that are available. In the rural healthcare side, the maternal side is really taking a knock. And I do not understand, because if we cannot get doctors or, for lack of a better word, specialists in those areas for high access to quality care. There are specialists under the nursing field that can be deployed there. But you find that the resources, are being kept into the city centers. For me, for some reason, I would say I see a wasteful expenditure. When you go to a district hospital, you find an advanced midwife. That is a nurse that specializes in delivering and baby care. And you find a gynecologist or an obstetrician. I feel that our rural areas should be enjoying, some of these specialties that are out there, so that we try and balance what is available in the city and try and balance with what is available actually in the aspect of our local care. Resource mobilization needs to be really intensified. Improvement of digitization. That's why I'm saying I'm welcoming the EVD program that's registering everybody, because to me it says we can actually get a national system that even registers patients who are on ARTs, because you find now as healthcare workers, because I need to speak when I'm in Gauteng with a nurse in the Western Cape in a form to say, this is Fikile, this is what she is on, this is how far I've come with Fikile. You find us having to be moving with paper, and if there was a system that we could be accessing, patients would not be having to heavily come to access before they can even go to other provinces, So, but because at the end of the day, we're looking at quality comprehensive care, there are measures that we tend to actually go down, and we tend to do as workers that actually are not working. Effective implementation of mechanism of curbing corruption and looting. We can no longer sit and watch monies go down and actually want people to smile when there is no bed. How many hospitals have we built? During this time of COVID, we know very well our mother and child units, women are giving floor on the bed, not because people want to, but because there is also no system of monitoring the bed acuity. We saw how it became such a hassle when ICU beds, needed to be clubbed together so that we prioritize those in need at that particular time. These are where I feel that technology actually should be coming in. Healthcare, especially public healthcare, it is so slow in transformation in terms of in terms of technology. And I'm wondering, since we're moving to the universal coverage, how are we going to solve some of these challenges that are out there? But we need to be intentional. We need to
Right
be
there,
deliberate.
Fikile, because I think
Thank you very
that's
much.
a pivotal place to then segue into the following three speakers who are already working in the space. They're already working with solutions that could possibly be implemented in a South African context. One or two of the examples, in fact, already existing in South Africa that will hopefully seek to address some of the challenges that you are highlighting. I agree with you. The pandemic presented a wonderful opportunity for South Africa to really review how our health system is delivering access to healthcare to ordinary South Africans. And as you say, we have not lived up to the mark, unfortunately. There is an intention to have a national health insurance coming by 2026, I believe. Yeah, wonderful opportunity to try that, to trial it. And unfortunately, we have not been able to get off the mark with that. Well, William, you are the first of the speakers who is already playing in this place. Dr. William Mapham is a founder and CEO of Vula Mobile and believes that every person must have access to the best possible healthcare, especially those in rural, remote, and underserved areas. Both Fikile and Russell highlighting that the services you get in a Cape Town, a Johannesburg, a Durban, completely different to services you'll get in Mkungundlovu, in Kumbu, in Emadwaleni, which is an area you're going to take us to today. Good afternoon.
Thanks so much. Just going to share my screen. Yeah, my real passion is, my name is Dr. William Mapham, and my real passion is improving healthcare in rural areas. I'm from the Eastern Cape, which is one of the more rural provinces in South Africa. And during my medical training, I did all my electives there. The minute I got opportunity, I would go back and learn from the doctors on the ground. And eventually, when we qualified, we decided we want to go back there and make the biggest difference we could possibly make. So we went to Madwaleni Hospital, which at the time didn't have a tar road there, and no doctors had worked there for some time. You probably know that South Africa actually has a nursing-based healthcare system. So there are plenty of amazing nurses there, a lot of local healers who we worked with. But it was quite remote. This is the road to my first job. It was an hour-and-a-half drive to fetch petrol. So you can imagine logistics were quite tricky. And the nearest ice cream was 3 hours away. So it's kind of our measure of how rural we were. We really did our best to work at that hospital. We recruited a lot of other health workers, physios, more nurses, doctors. And in fact, if you go back there now, you can actually specialize in family medicine. So it shows if you do put a lot of effort in, change can happen over time. It wasn't all good news. This is a letter that I wrote myself in 2004. The patient had come with an eye condition, and I didn't know what it was as a junior doctor. I only had 2 weeks of eye training at medical school. And so I wrote this letter for him. I said, look, it looks serious. Here's a letter. Please go to Mthatha. It's our nearest eye clinic. It's only 3 hours away, and hopefully they can help you. 7 years later, I went back, but now as a specialist ophthalmologist, and he came with the same letter that I'd written 7 years previously. He had gone blind in that eye, and he was so hopeful because now he could see a specialist. And I realized then as a specialist, it was a simple condition. We had the medication he needed the first time I'd seen him. I just didn't know as a junior doctor. However, you know that many patients travel huge distances. And so in the Northern Cape, your nearest eye clinic to Nababit is about 7.5 hours drive away. Imagine driving 7.5 hours to go and see your doctor. However, when I went to specialize, this is me specializing at Tygerberg Hospital, I realized the problem wasn't just in the rural hospitals. Here's me as a public sector specialist. I'm seeing patients, I'm teaching students, more patients are waiting. There's a never-ending queue, and that phone in the corner just rings off the hook with other rural health workers, GPs, nurses, trying to get hold of a specialist. So we really had to design a problem that worked for everyone. So in terms of co-creation, it was fascinating because I actually met a designer, and we met in Agulhas, which is where the Indian Ocean and the Atlantic Ocean actually meet. So in a way, it was the world of design meeting the world of medicine. And then the third leg of that was technology. So we designed Vula Mobile. It's an app that health workers download, register, and start using. And it connects the primary healthcare workers with specialists in a secure way, in a very efficient manner. We built our own chat services and so on, so that it actually uses 20 times less data than WhatsApp. So it actually can be used in areas where I'm from. We started in ophthalmology, which was one specialty, and in our first month, we were so happy because 25 patients were referred through the system. It's now available in 53 specialties. It's used in 6 provinces so far, and 1 VRULA is sent every minute. So by the time we finish this meeting, 90 patients would have been helped through the system. It's important to note that we talk about telemedicine, but telemedicine isn't always practical. If you can imagine me as a public sector specialist, I can't be just on video. We don't have enough resources. So we built an asynchronous chat service so that the health worker can send the patient and the specialist can then reply when he or she has time. And that makes it practical in our area. Often the rural hospitals don't have vision test in kits, for example, in the hospitals themselves. So we built a vision test into VRULA. We built a Burns calculator. And it's very much co-creation because we work with the specialists on the ground to work out what information they need. We work with the rural health workers to see what's the most efficient way of sending that information, and then we design the system for them. So a bit of history, we were first featured by Amazon actually in 2016. World Bank featured us in 2017. We got our first provincial tender, which was in the Western Cape in 2018. So we worked with the Provincial Department of Health. In 2019, we won MTN Best Health Solution. We beat Discovery into second place. So often public sector can beat the private sector. And then obviously last year, heavily involved in the COVID response, and happy to talk about that. It's very important in the medical world to actually publish your results and to actually get other people to analyze what your impact is. So what we showed is when VRULA is used, in 30% of cases, the primary healthcare worker can actually manage the patient remotely with advice from the specialist. So it saves a huge amount of travel time for patients, and gradually over time, health workers get upskilled. And because we publish the response times to the specialists, they do get a little bit competitive within their departments, and the average response time is 15 minutes. So this means as a rural nurse, as a rural doctor, you get advice almost while you're with the patient. So you ask the patient to wait a few minutes, and then you can help them. I just want to talk a little bit about not COVID, because we're all talking about COVID and these different waves. We're approaching the 3rd wave. But every specialty in healthcare has had their own wave. And because we're in the Desmond Tutu Institute here, I thought I'd show you what happened to TB. So during the lockdown, very few patients were actually referred to TB treatment centers. Many clinics had closed. People were afraid to get their medication. And what we saw immediately afterwards was a sudden onslaught of patients coming into the TB centers. Russell talked about diabetes. The same happens with endocrinology, which is basically care of diabetic patients. So this is a huge problem that we need to solve, and it's important to think of the healthcare system not just about COVID, but in a comprehensive manner. And so what's quite nice, there was a life Estimani tragedy some time ago regarding mental health patients, but now using VRULA, the Mental Health Care Act form was actually sent in advance. So hopefully this will never happen again if people are using VRULA. And basically this is one of the health workers working in emergency medicine, and she loves the fact that the forms can be sent in a secure and compliant manner. And this is Saad Lari. He's based at Khayelitsha Hospital, which is just down the road. He said it used to take about 45 minutes for him just to phone a specialist. And now using VRULA, he's actually getting that help almost immediately. So we just thought a little bit about the public sector because we talked about it being inefficient, but we're going to show you some ways where it's becoming more efficient. So Butterworth or Tluwa, which is a hospital in the Eastern Cape near where I'm from, the nearest orthopedic clinic is in East London, so it's an hour-and-a-half drive to see an orthopedic surgeon. When we showed them where all their patients were coming from, so we give them their monthly data, and we'll talk about big data, machine learning, and these are all things that we need to start concentrating on. We actually showed them that virtually all their patients came from Tluwa, Butterworth Hospital. And we also showed them that don't just send any doctor there, we showed that the orange and the blue there were hand and feet injuries. So now they can send the right doctor there once a month, rather than all those patients having to travel through every month. So we can do a lot in the public sector to help ourselves. To give a complete opposite of what happened to me, as a sister, Elise Mantonnison, she's a nurse in Vredendal. Vredendal has recorded the highest temperature ever in South Africa, so if you want to go to a hot place, this is the best place to go to. She learned case by case, and then after 2 years, she stopped sending us patients and stopped asking us for advice. So we were quite worried. We thought maybe something had happened to her. But when we called her, she said, no, she's fine. She just knows what to do now. She also used the data collected over those 2 years to show what type of eye clinic should be in Vredendal. There the Department of Health is. There's a lot of public sector workers doing great work, They open the eye clinic in Vredendal, all the patients get treated there, and once a month the surgeon goes to operate for her. It's a complete opposite of what I experienced when I was a junior doctor. So if you look at the Vula logo, it's connecting the dots. It's like the African bees. Healthcare needs partnerships. It's best delivered through partnerships. Bill Gates doesn't own healthcare. The public sector needs to work with the private sector. Doctors must work with pharma companies, NGOs, and so on. It's all pulled together. So I just thought I'd show some of the partners because CDI were actually one of our partners a few years ago. They believed in what we were doing. There was quite a rigorous administrative process. I don't know how you get corruption because there was such good rules and regulations in place. We got some funding from them, which really helped us bridge the gap between just doing the work and also creating more partnerships. So I just wanted to thank the CDI for that, and Ryan Roda, who worked with us in particular. And if you look at the world of design, I thought I'd use a Cape Town example. There's an art museum here. And what they did was they took an old, dirty grain silo, which had sort of 9 round blocks. It was an ugly building. You can't really do much with it. And they wanted to turn that into an art gallery. But what they did was they hollowed it out. So they actually deconstructed the building to make something that's really beautiful inside, and it's now one of Cape Town's most popular buildings. So sometimes what we need to do is, rather than constructing more and more things and layers on healthcare, we actually need to deconstruct it, take away administrative processes, take away the need for doctors to have to waste time on telephones, to take away the need for people to have to travel for education, take away the travel time the patients have to endure, and really hope that we can build a better health system for all. So yeah, hopefully you all partner with us, and if there's anyone else like to partner with us, you're welcome to come to my office. I'm from the Eastern Cape, but you're welcome to meet me, or I'll come to you. These are my contact details, and happy to answer any questions later.
You'll notice that William has placed a wonderful picture of the view you'll be enjoying from his office when you visit him in the Eastern Cape. Any idea of how many people you are currently impacting on the Vula platform, both patients and I suppose healthcare workers?
So currently we're 20,000 health workers registered on Vula.
20,000 across the land?
Yeah, and about 4,000 health facilities who have Vula users in them. And currently it's a patient being helped literally every minute. And in total, I think we just reached over 470,000 patients earlier today, actually, I've checked.
Oh, congratulations.
So we're aiming for 500,000 as soon as possible. And I think in preparation for the third wave of COVID, we need to all start working together now to prepare for
for sure.
Yeah.
I have to ask this question. Percentage of accuracy, that's not the proper word, you know what I mean? Where a doctor that's sitting 1,500 kilometers away is consulting on a patient that they have not seen. So relying on the healthcare worker, who could just be a nurse, in accurately noting what the symptoms are. How many times do you get it wrong, basically, is what I'm asking.
So I think doctors are naturally cautious. So if they don't know, they will ask for the patient to be sent through. So I can give you an example. There was a patient referred to me who had a chemical injury in the eye. This is an absolute emergency. If I wait for the referral, the patient's going to go blind. So I showed the doctor what to do. There's a special technique using a piece of tubing. It looked like he had done the procedure correctly, but I asked him to send the patient to me anyway. And they'd actually done a perfect job. Patient went home the same day with his vision.
Nice.
Normally, that would require 3 weeks of rehab at Tygerberg Hospital, and maybe the patient would get their vision back. And then a while later, another child was referred to a colleague of mine, again with a chemical injury. The doctor, a different clinic, had already done exactly the right technique. So before they even made the referral, they'd said, is this right? And so I think when we went to analyze that, how did this get across? But it turns out that the clinics run their own sort of education once a week and they all meet.
Very nice.
And now you've actually got shared information. So you teach one, you see one, and then you do one. That's kind of a common phrase in our medical teaching. So I think, yes, you could get it wrong, but doctors are cautious and they always want to check sometimes.
So it is then possible that the 220 billion rand we're spending every year on healthcare could, I suppose, share more love if we were to incorporate technology and platforms such as Vula into the everyday workings of healthcare workers.
Yes, I think we've never had a better opportunity, and people talk about the regulations, but maybe the way that we should think about more forward thinking is you should actually be fined if you don't use technology. Yeah. Because it is a resource. There are people on the other end of the line, and this is the best possible healthcare we can give to people in each area. So I think there's a lot of work to do, but I think you've seen some people on the call already who are determined to make the change, and we all got to work together.
Thank you. Thank you, William. Very, very interesting indeed. We continue with the focus on solutions and now introduce Dr. Riyad Domingo. He is the co-founder and CEO of South Africa Makes, which is an award-winning and internationally recognized medical device digital manufacturing company. He's received numerous awards from the Department of Science and Technology, the National Research Foundation, the Medical Research Council, and the Oppenheimer Memorial Trust. Most recently, he's been provisionally accepted as a Harvard South Africa Fellow to attend Harvard Business School in 2021-2022. And I imagine, Riyad, because of the pandemic, that's meant you delaying your trip to Harvard, has it? Good afternoon.
Hi, good afternoon. How are you?
Very well, thank you very much. How are you doing?
I'm good, thank you. Well, not necessarily delayed, but it has sort of accelerated because we do see the need for, this global collaboration in dealing with the pandemic that we, as a society need to work together. So we need to bring clinicians, we need to bring technology commercialization experts, people from the public and private sector all together to work towards a common goal in eradicating the pandemic. I have just prepared a quick presentation just to highlight some of the challenges that we've been encountering with regard to, the development of innovation in South Africa. So thank you for the introduction. I'm one of the co-founders of South Africa Makes. We're a medical device company using digital manufacturing, and I'll get into digital manufacturing in a little bit. We've been featured on TEDx, Bruntains, and the Mail and Guardian, and most recently, last week it was, we were nominated, or we won Fast Company's awards for one of the most innovative companies in South Africa. However, none of these accolades mean much, in the pandemic, because our mission has always been to drive the equitable access to medical devices in Africa. With healthcare being a critical area for service delivery on the continent, and yet despite its status as one of the largest medical device markets in the region, more than 90% of medical devices are still imported into South Africa. Pandemics have been around since, we started recording history. The 1918 flu pandemic, wiped out something close to 20 to 50 million people worldwide. Here in this photograph, in 1918, we see volunteers and nurses from the American Red Cross preparing for home visits, providing supplies and services to flu victims. Now, the more things change, the more things remain the same. Our nurses, so valiantly led by Nurse Fikile, who spoke earlier, face the same challenges, if not more challenges now in 2021. But I'm really happy to see that the faces have changed. The faces of our frontline healthcare workers have now changed. And in 100 years' time, we'll see Nurse Fikile and her colleagues in photographs highlighting the amazing work that the frontline healthcare workers have done. And while the far-reaching effects of COVID-19 have been felt across the world, we can look to the history of other pandemics, such as the 1918 flu pandemic, to see just how innovations have emerged because of them and have become part of our daily lives. For instance, this pandemic, the 1918 flu pandemic, led to a rethinking of public health policies around the world. And this probably leads into, this talk around the national health insurance policy. We see, as the previous speaker has mentioned, we see healthcare practitioners focusing more on the occupational and social conditions that promote illness. We're not looking to just cure illness, but we're also looking at ways to prevent it. And 1918 has also led to innovations in vaccinations. Most governments also sort of embrace this concept of preventative and socialized medicine. We see the adoption of centralized governmental healthcare systems, and we also see the promotion of employer-based health insurance, or what we see here in South Africa is, company-orientated medical aid plans that offer coverage for a number of their employees. But, what about the current pandemic? What sort of innovations are we using right now? So within our company, we've highlighted the global shortage of nasopharyngeal swabs. Now, nasopharyngeal swabs are needed to collect samples for effective COVID-19 testing. Swabs are often used for other upper respiratory tract infections, and they are the critical components for PCR testing. And thus far, one of the most effective testing methodologies available to us. We, together with other organizations around the world, have adopted 3D printing or additive manufacturing as an innovative method in producing these urgently required medical devices for COVID-19. So I am aware that some people may be unfamiliar with the concept of 3D printing, but 3D printing or additive manufacturing, these technologies create parts from computer-aided or CAD models by successively adding material layer by layer until a physical part is created. We like to think of it as a combination of elements, an ecosystem of technologies, if you will, such as the SLA or low force stereolithography seen in this video, the materials and consumables, designs, and the infrastructure that is required to support this manufacturing technology. Together with partners around the world, these include Formlabs and Autodesk, and also the Kingdom of the Netherlands, we've created our own innovative 3D printed nasopharyngeal swabs, locally manufactured, creating jobs while conveniently being able to produce these critically needed devices in the country. Local manufacturing means reduced CO2 emissions through the reduction of unnecessary logistics, and results in the reduction of the cost of the transportation of these goods. We are already beginning to see 3D printing make products at scale in hundreds of thousands of units, as with the nasopharyngeal swabs, more cost effectively and greener than ever before. We have seen that not having access to these products, as Sister Fikile has mentioned, could be the difference in saving lives. We've seen that with the COVID-19 response, and by using additive manufacturing or other technologies, we can shorten the supply and distribution chains and produce inventory as required. So what do we think about the future? I mean, what are the future healthcare therapies that we will see that are driven by innovations that were prompted by the COVID-19 pandemic? We're quite excited within our own organization to see advancements in 3D printing and additive manufacturing that would benefit the healthcare sector greatly. We're seeing huge inroads in data science to help inform our decisions and refine public healthcare strategies. We're seeing advancements in biomedical engineering and biotechnology, helping produce better products. We've already seen the same mRNA technologies that have led to the development of COVID-19 vaccines in a record time being applied to the treatment of other diseases, including HIV and cancer. We'll see, artificial intelligence step up to optimize the delivery of tailored therapeutic approaches, not just for one single ethnicity, but for all, and leading into this future of precision medicine. We're also quite excited at this drive towards advanced material science to create innovative products that are designed to offer better patient comfort and improved efficacy, especially in transplants. Together we hope that these innovations will be used in areas with poor infrastructure and under-resourced healthcare systems. So we're really grateful to have worked with a number of amazing organizations, and I would just like to acknowledge them here. I'd be happy to answer questions now or later, but I just wanted to provide a brief bird's eye view overview of what it is that we're doing and hopefully encourage discussion as we go along. Thank you.
I suppose the only and the most important and immediate question that comes to mind is cost. Whenever we think of new technologies, introducing new solutions, there is a very, very expensive price tag that comes with it. There is the advantage of manufacturing the swabs in South Africa, because then we're not, contributing to climate change challenges and so forth and so forth. But what would have been the cost of your company producing those swabs compared to them having been imported from the Netherlands, for example?
That's a very good question. We're always, one has to approach these things holistically. So, from our point of view, ours are comparable to the ones that are imported from the United States and Italy. So they are on par with the pricing. One of the big challenges, and we've seen it quite recently, is the vulnerability of supply chains. So we all know about the Ever Given that got stuck in the Suez Canal a few weeks ago. We're going to start experiencing some coffee shortages. Some of us that drink coffee will realize that our beans didn't come in because it was stuck on the ship. Those are the vulnerabilities that we face with regard to medical device items. When we are waiting for these products to be brought in from elsewhere around the world, we're looking at the CO2 emissions that come off. We're looking at the fragility of the supply chains that we currently have in place. And like all of the other speakers have mentioned before, there is a need to innovate within the healthcare system that we currently have. It might not always be the be all and end all, but we do need to bring in new approaches, not necessarily just to completely circumvent the global supply chain network that we do have, but perhaps to supplement it. So, for instance, when we see a massive outbreak occurring in one area, it might make more sense to produce local nasopharyngeal swabs within a matter of days to actually target that sporadic outbreak, so that we can put those people in isolation and prevent the spread of any infectious disease before it becomes a healthcare burden. Typical supply chains, we're going to look at a few months. I think some of the speakers have highlighted some of the challenges in the procurement process and the tendering process, and but actually upskilling local capacity and local talent to actually be able to provide those solutions on demand is in future going to become invaluable.
Very much indeed. I think the Ever Given is still stuck in the port of Cairo. The Suez Canal Authority is refusing to let it go until they pay the $900 million that it cost the Suez Canal Authority to move it out of its wedged position. So if you're a maritime lawyer, you are making a lot of money right now. Our final speaker today is all the way from Utrecht in the Netherlands. His name is Erik Pentinga. He's an African program manager at Task Force Healthcare, which is a public-private platform for the Dutch life sciences and health sector. The innovative solutions we've explored up until now have pretty much been homegrown and in South Africa. And Erik, we thought we'd go to the Netherlands and find out what you guys are doing there that could be of use to a South African and indeed an African context. It's lovely to have you here, and happy King's Day for yesterday. Good afternoon.
Well, thank you for the warm welcome, Africa, and thank you for having me today in this session, in this very interesting session. And I do think that the previous speakers touched upon many aspects of the health sector and also the developments going on. I learned a lot about it, and I also learned that on the one hand, there are some system challenges, so to speak. And on the other hand, there are already innovative solutions being developed that hopefully can be implemented further any day soon. I prepared a slide deck, bringing you a little bit to the Netherlands from South Africa to tell you a little bit more about the impact of COVID-19 on the Dutch health sector. and also touch upon various Dutch smart solutions that we have been working on, including some of the Dutch solutions that are already being implemented in countries abroad and might be interesting things to be inspired by. Also in terms of that it might be interesting to see if those solutions also would work in the South African context. So I will share my screen now. So Task Force Healthcare, that is the organization I represent. It's the public-private platform in the Netherlands for the life science and health sector. And this year is our 25-year anniversary. We are in the business of improving healthcare together by improving the right people. For us, that starts in the Netherlands. So together with the public sector, but also the private sector, we look at the healthcare challenges in the world. And often the challenges that we face in the Netherlands are also being faced by countries in different parts of the world. And of course, in the Netherlands, we are working on smart solutions, and in other parts in the world, they are also working towards smart solutions. And we try to connect the Netherlands with the world as best as possible to make sure that there is a lot of knowledge exchange and also foster partnerships between countries, between stakeholders to work on those smart solutions and implement them in each other's health system. So I've been involved with the activities towards South Africa, I think since 2015. I also had the pleasure to travel to South Africa, beautiful country. Back in the days when the physical visits were still possible. And more recently, we co-hosted various virtual activities to also connect South Africa and the Netherlands in these difficult times of COVID. And also connect stakeholders within our health system to each other so they can discuss potential solutions for the health sector. So I will just start with the impact of COVID on the Dutch health system. And actually, this is a picture of a helicopter on top of the Erasmus University Medical Center in Rotterdam, just before they were going to transfer a COVID-19 patient to a different hospital in the Netherlands. The ICU capacity was limited, of course. It's everywhere in the world. And I think on average, a Dutch hospital has around 10 to 14 ICU beds. And of course, there were way more COVID patients that needed the ICU bed. So they were transferred to different hospitals in other parts of the Netherlands. But in the end, we also reached our limit. And we built new ICU capacities. And we also start collaborating with German hospitals. So they can also receive our corona patients. So that was a large impact, of course, on ICU capacity, but also on the health workforce in terms of the hours they had to work. On the other hand, of course, the non-COVID healthcare was completely stopped in each of the COVID waves we have had in the Netherlands. The first one, obviously, in March, April last year. The second one somewhere around October. And now, currently, we are in the third wave, or maybe at the end of the third wave, because the restrictions are being loosened here in the Netherlands. And actually, yesterday was our first day without a curfew. So and the shops are opening up again. So it has made a major effect on the Dutch health system. But on the positive side, we also saw some interesting developments in the Netherlands. The Netherlands is often already regarded as a front runner in digitalization, often also dubbed as a test bed for digital solutions. And in COVID times, we even saw an upsurge of digital solutions being used in practice, mainly in the areas of teleconsultation, telemedicine, but also improved data sharing and e-learning, including for health professionals that were encountered with new situations with patients having COVID or needed to treat patients in a COVID-proof setting, but obviously they couldn't go to a physical class. So a lot of that was being shared via e-learning tools. Yeah, actually, in I think it was only 2 or 3 weeks, the Dutch government, together with Philips, the large healthcare company, and the University Medical Center of Rotterdam, and another hospital in the Netherlands, they have set up an online COVID-19 portal to address the urgent need of transferring patient data amongst hospitals. Like already mentioned, patients had to go from one hospital to the other. And unfortunately, in the Netherlands, we are still debating whether or not we would like to have a national electronic health record system that is highly interoperable. Unfortunately, due to discussions around privacy, that hasn't been in place yet. So, but we were able to put in place a similar but standalone system for COVID patients, and it was of course built privacy by design. And the interesting part was that there was an opt-in needed by the referring hospital and the patient. So also the patient was in control of his own patient data. So, and I also mentioned the difficulty to continue non-COVID care, and of course we also have a large the primary healthcare system in the Netherlands with a lot of healthcare workers or nurses that are normally supported by higher-end healthcare professionals, but to reduce travel and reduce exposure to contacts, several interesting solutions popped up, including working with a smart glass where the healthcare professional could assist the healthcare worker directly via a live stream. I don't know if you already have one in South Africa as well, but in the Netherlands we have developed an app which can track whether or not you have been in contact with a person that was diagnosed with COVID. It's based on Bluetooth technology. Again, privacy by design. It took some time due to all the discussions around privacy, but I think somewhere around the summer we were able to launch this app, and now it has around 5 million users out of the 70 million inhabitants we have, so that's around 30% of the population. So that is quite a big development that also took a lot of effort from the government. And I thought it was also fun to mention this example because the previous speaker was touching upon 3D printing. Of course, in the Netherlands, we also had a shortage of personal protective equipment. So also a society of 3D printers, they started the Makers for All initiative to print PPE solutions. And well, on the other end of the spectrum here in the Netherlands, we are working on very advanced 3D printing techniques, including printing heart valves. And because there's also a focus on design in this event, and I thought it was fun to also highlight this example of a Dutch artist that worked on a solution called Urban Sun. It works with new far UV light. It has a wavelength of 225 nanometers, and that type of light is actually able to sanitize viruses safely. So this was highly in the news last summer, also to use in public spaces. But actually, I haven't heard from it since. But I don't know if it's been implemented in many places. But it's a highly interesting development coming from a design background. Well, and yeah, well, you already shared a lot about the South African healthcare sector and often the local context in which healthcare professionals need to work. So I thought it was interesting to touch upon various examples of the solutions for more lower resource settings. And I think an interesting one that also represents a strength of the Netherlands is the CAT for COVID solution developed by Delft Imaging. CAT stands for computer-aided detection. Delft Imaging is very advanced in artificial intelligence. Normally, they can analyze X-ray images for tuberculosis. They did several projects in South Africa, including screening prisoners to detect tuberculosis. And after COVID, they were successful in also detecting COVID-19 on X-ray images. And they have been implemented this solution in various countries around the world, including African countries. And it has proven to be a very efficient solution for those areas in which testing capacity is lacking due to the absence of testing materials. And in most regions, there is a X-ray available. So in that way, it was a highly welcomed solution in various parts of the world. And the next solution, and actually we have seen more similar solutions to this one, is the Safe Care for COVID app developed by Safe Care, which is part of the Pharmaxis group from the Netherlands. It's a Dutch NGO slash social enterprise that is actively involved in health financing, health quality in African countries, mainly in Kenya, Tanzania, Ghana, Nigeria. And of course, they wanted to inform and share the best information available to the health facilities they normally work with. So they developed the app, and the health facility could check upon their availability of equipment, staff, and supplies related to COVID, and also upgrade their processes and knowledge to treat patients. And this was also a very interesting development. Actually, it was an app developed in the Netherlands for Dutch COVID patients for self-monitoring and remote guidance for those patients that didn't need to go to the hospital. It is Android and iOS based, and the Dutch Entrepreneurial Development Bank, they financed various projects in Ghana and also now Kenya to bring that app to those countries. And they were quite successful in detecting COVID cases amongst people that would normally wouldn't have let them test it. So in that way, they could go into isolation and also reducing then the spread of the virus, of course. And but it has been successful, I already mentioned it. And now they also are working on an SMS-based solution to also cater those parts of the population that do not have access to a smartphone. So yeah, I already talked a lot about the Dutch health sector and its various Dutch solutions. Maybe it's good to zoom out a little bit. Also, in this perspective of maybe future steps in fostering partnerships between South Africa and the Netherlands. If we look at the Dutch life science and health sector, mainly those that are active in the international domain, we see that the Netherlands is very strong in digital health solutions, mainly in the field of connected care and analytical and artificial intelligence. We also see a lot of affordable, innovative medical devices being developed here in the Netherlands. Of course, affordability is also a big topic here in the Netherlands. innovators are working on solutions that can bring down costs. Also in relation to South Africa, we've seen in the past that various Dutch companies are active in the field of health facility design, build and equip, turnkey projects to cater those areas that are in need of new healthcare facilities. In the Netherlands, we are very strong in rehabilitation after surgery or with long-term conditions, and also in the field of prevention and stimulating healthy living and supporting those in need of care when they are aging in the later phase of their life. And in the area of public health system strengthening, we see a lot of NGOs, knowledge institutes that are active with healthcare programs in the field of modern child care, community health programs. Within each segment, we have seen various Dutch organizations that already established partnerships with South African counterparts. So that is interesting to see. Maybe if we look more towards the future, and I will only briefly touch upon this. In the Netherlands, of course, we do not stand still. We like to innovate a lot, and we have a mission-driven innovation policy, and that is mainly focused on making sure that Dutch inhabitants are able to live at least 5 years longer in good health in the future, and also decrease the health inequalities between the lowest and the highest social income groups by 2040, because we see that the more fortunate people, well-educated people, they tend to live more healthy and longer compared to the less fortunate people, even in the Netherlands. So that is the central mission, and there are 4 underlying missions, mainly focused on what I already touched upon in previous sections, stimulating a healthy lifestyle, a living environment. In the Netherlands, we also have a big increase of the non-communicable lifestyle-related diseases. In the Netherlands, we are focusing heavily on providing the care in the right place, moving away from giving care in hospitals, in clinics, and making sure that people receive more care at home, also when they are older. We have a lot of people with chronic diseases, and of course it's a challenge to overcome those diseases and also manage those patients with long-term conditions. So we see also a lot of apps being developed for that, so people get the right information, notifications, and can monitor themselves to make sure that they can live as best as possible with their chronic disease. The Netherlands is a slightly aging society, and that also means that the percentage of people having to live with dementia are growing. That's actually a large burden on the health system. It's quite cost intense care. So we are investing both in research to overcome that disease and also in best treatments for patients with dementia.
Let me break your word there, Erik, because we are fast running out of time, unfortunately. We've been very ambitious this afternoon in getting 5 amazing speakers to not only, I suppose, paint a picture of some of the challenges that we are facing in South Africa, but more importantly, to bring about fantastic solutions that your organization, for example, is sharing with us. I have no doubt we will invite you again in one of the upcoming 4 creative exchanges that we're going to be scheduling. Thank you very much for your time and for your wonderful ideas. And if I can beg for just 2 more minutes of your time, Sebastiaan, as I said, we started this afternoon spending quite a bit of time in painting what is at times a bleak picture as far as the state of healthcare in South Africa.
Yes.
But then absolutely inspired by 3 amazing innovations, solutions, and ideas to address some basic things really that we can overcome quite easily in this country.
It shows you the resilience of South Africans, the South African private sector, It shows you also how we can connect together, because you saw the Dutch examples. And that's also where I think there's an opportunity for us worldwide to be connecting even more. And in that respect, I want to mention that we'll have a virtual trade mission, because of COVID times, virtual. A trade mission coming in on the health sector also, technology solutions to health problems, in June, 22nd to 25th of June. And of course, on the Dutch side, we're looking for Dutch companies to come and explore South Africa. But on the South African side, we would like also call on South African parties, private sector, government, whoever, to see whether you want to invite these and see whether you can work together. So get into contact with us. There's, for the Dutch people, there's the RVO website, which the Dutch businesses will know. On the South African side, get into contact with our embassy in Pretoria or with our Consulate General in Cape Town, and follow us on Co-Create SANL on Twitter or our Facebook sites, because it's going to be interesting. It's exactly what we're looking for. And the conversation today, I agree with you, Africa, it shows you that even though we have the bleak picture, that there's so many huge challenges that are not yet overcome. Yeah. There are structural problems and challenges in this country, which of course are connected to what we're facing today. And some of them are unique to South Africa, but some of them are also worldwide. And we really, really need to collaborate. And it's not just about doing business, it's about really finding the solutions together, as you can see. And as you were doing, William, I was really inspired. And also the other speakers, like, what is possible?
And what is possible right here on this very African continent. Exactly. And it was quite heartening, I suppose, to hear from Erik and realize that they were facing similar challenges, yes, albeit in a different context, but they were facing similar challenges to those that we are facing. June 22nd to 25th is going to be a virtual trade mission. You can do it from the comfort of your lounge or your work office. If you choose to, please get in touch with the Dutch Embassy if you are in South Africa. And of course, if you're listening to us from the Netherlands, you know how to go to the RVO website. Where to from here?
From here? You mean in this process to co-create design?
Yes, of course.
Okay, well,
I always bring it back to here.
Yeah, that's good. That's
good.
And
I know you've got a lot of other things you're worried about and have to be concerned about, but ultimately we've got 4 more of these, yes. And the focus is going to be on solutions.
Yes.
What would you like to see unfolding in the next 4 engagements?
Well, more of this. Creative exchange, people getting together and being inspired by each other. So I'm also hoping that after this meeting, these people that are talking to each other and people are listening will contact each other. Yeah. Because that's basically really what we want to get out of this. Yeah. The new partnership arrives from this. And then like a year from now, we'll hear of new solutions because of these people meeting their minds together on this platform. So Africa, under your moderation, like really, I'm hoping more of this in the next creative exchanges.
No doubt. We are, by the way, I don't know which camera. We are recording this, and we'll be sharing with all of those who are attending. I know many of you have asked questions on the chat function. If the speakers have not already answered your questions, we'll make sure that we get the answers from them and we email them to you. So do not be heartbroken at the fact that I did not get to answer your questions today. As I said, we're a little bit ambitious this afternoon in trying to get all the speakers. Erica, the next one is going to be on the 26th of May, I have decided. It is the last Wednesday of the month of May. What are we likely to cover next in that topic?
Well, we haven't quite decided yet, Africa, but thank you for setting the date for us. We will put in place the arrangements. I'm thinking, the issue of food security and access to water and sanitation were issues that we were raising before. And I think that Russ and I very eloquently put that on the table as the kind of precursor actually to a good, healthy nation is what are people eating? What is the quality of the food they're getting? How are they getting food? What are the problems in our food security system, which we know is also systemically challenged. So I think that might be a good topic for the next one. And then I just wanted to say that I think that you might ask me another question, but I'm
no, don't worry.
Is that I think that the value that I also felt today, and particularly when William was speaking, was the value of like real experience on the ground. Is that William worked as a doctor in the environment. He understood the problem intimately from the perspective both of the supply and demand side. and how important it is bringing all of that expertise together to find solutions. And I kind of feel that that's what's happening with Wheeler Mobile, which is extraordinary. And I just want to say well done.
Thank you. Thank you very much. 26th of May it is. If you are working in any way in the food security space and you'd like to get in touch with us, please do. We will certainly consider having you as one of the speakers. Let me say thank you very much to Russell Rensburg from the Rural Health Program, Fikile Dikolomela-Lengene, the First Deputy President of the Young Nurses Indaba Trade Union, to Dr. William Mapham, founder of Wheeler Mobile, Dr. Riyad Domingo, CEO and founder of Africa Makes, and of course, Erik Pentinga, who's a program manager for Task Force Health, and Sebastiaan and Erika. Thank you very much, everyone. It's been a wonderful, wonderful engagement.